Okay, we're going to cover Chapter 19 with our first Tegrity video. The title of this chapter is Nursing Care of the Family During Labor and Birth. Here are your objectives. And we start with the first stage of labor. We have discussed that labor begins with regular uterine contractions and ends when the cervix is 10 centimeters and 100% effaced. We're also going to talk about obstetric triage and EMTALA. Those are laws that labor and delivery nurses have to follow, and the important prenatal data that you have to cover when you're admitting a patient. So the first stage of labor is broken into three phases. Those three phases are the latent phase, up to 3 centimeters, the active phase, from 4 to 7 centimeters, and the transition phase, from 8 to 10 centimeters. This illustration shows at the top a mother's abdomen that during a contraction, the abdomen contour changes before and after. You can, when you're palpating these mothers, you can feel, and sometimes the moms will describe it as they feel the baby balling up, but really that's a contraction. At the bottom, you can see the wave-like pattern of the contraction activity. Here it's got a good picture of frequency, which is the beginning of one contraction to the beginning of the other, normally measured in minutes. The duration of contractions, which is measured from the beginning of one contraction to the end of the same contraction, and that's usually measured in seconds. You can see the increment is as the contraction increases. The acme, or sometimes you'll hear this called the peak, is where the contraction is at its strongest, and then as it goes away, it's called the decrement. And then you've got the uterine palpation in between contractions, and that's your resting tone. You want that to palpate as soft. For the first stage of labor, we're going to look at assessment and nursing diagnosis. Determining whether the patient is in true or false labor is based on the contractions, the cervix, and the fetus. On page 431 in your book, there is a box that you should be familiar with that goes over the teaching you can do with your patients. Next, here's where we wanted to talk about the obstetric triage and EMTALA. What EMTALA stands for is Emergency Medical Treatment and Active Labor Act. A lady is considered to be in true labor until a qualified provider determines that she's not. So what this law does is protect pregnant women during an emergency, regardless of their ability to pay, so whether they have insurance or not. Emergency rooms also have to go follow this law, so it's emergency rooms and labor and delivery. Essentially, patients have to be evaluated before you can even ask for any type of payment or insurance information. The qualified provider, the way this applies to labor and delivery, is the nurse. You evaluate and assess the patient. You call the provider, whether that's a physician or a midwife, and you give them a report, and then they help you determine if the patient is in labor or not. This diagram shows in the first picture a vaginal exam. This cervix, you can see where the finger is touching the tip of the cervix, is not dilated, is not effaced, and the membranes are intact. In B, you can see the cervix is effaced and partially dilated, and the examiner is palpating the sagittal suture line, and that's what helps you determine which position the baby is in, whether they're anterior or posterior or transverse, is following the suture lines and the fontanelles. Assessment and nursing diagnosis. Admission to the labor unit usually occurs after the patient is 3 centimeters. They can be admitted before, but they're usually, approximately 3 centimeters. For the admission data, the first thing you evaluate is their prenatal record. Hopefully their prenatal record you have access to on the unit, whether it's a paper chart or somehow electronic from the physician's office. You want to review the prenatal record to identify the patient's risk and what needs they have. For instance, a 40-year-old has different risk factors and needs than a 14-year-old. If the patient doesn't have prenatal care, you'll get an order to obtain baseline labs, and those are the same labs that you would normally find on the prenatal record for patients that have prenatal care. Their blood type, if they have the labs are their blood type, rubella status, and that HIV, hepatitis B is usually what's on there along with their CBC. When you're admitting a patient and they're in good hard labor, you want to ask questions between contractions. So as they are in labor, they can't answer if they're in real hard labor. Ask them between contractions. You also want to note their patient's age, their weight, vital signs, what kind of OB and medical history they have, their due date, their fundal height. You want to make sure their fundal height is consistent with their due date and the number of weeks they're supposed to be. Their labs, any diagnostic tests that they've had during the pregnancy, and then the details around the previous deliveries. That can give you an indication how this delivery is going to go. If they had a very fast labor last time, more than likely they're going to have a fast labor this time. The next thing you want to do is the interview. During the interview, you're going to determine the primary reason that the patient is seeking care. So they'll either say think they're in labor, their water is broken, they're having vaginal bleeding, decreased fetal movement. So the interview determines the primary reason the patient is seeking care. You want to know if their water is broke, what kind of contraction pattern they're reporting, their pain level, vaginal discharge, their respiratory status, any allergies they have, their birth plan, and their feeding plan, if they plan to breast or bottle feed. The nitrazine test is something you'll test to see if their membranes are ruptured. On page 434 in your book is box 19-1 that goes over the nitrazine test. You also want to assess the psychosocial factors, and one thing to kind of point out here is women with a history of sexual abuse. Labor can trigger those memories. Vaginal exams are intrusive. The monitors and the IVs, the interventions we do to these patients, so often make them feel restricted. So it's important to explain all the procedures and to support her. The last thing is stress during labor. Stress, patients, the way they cope, it's usually related to past experiences or stories that family members have told. For instance, if their mother tells how terrible labor was, how awful it was, it can be really scary for patients. So sometimes their support people really cause the greatest stress. You want to make patients feel comfortable discussing their feelings. Women with continuous labor support are more likely to have a vaginal delivery and better outcomes. So that continuous labor support can be nursing, it can be doula, it can be a significant other or another female the patient is close to. But we always have to remember that the support person also experiences stress. So the role of the labor and delivery nurse is to not only support the patient, but to support those that are supporting her. Next, you're going to take into consideration the cultural factors. Women may have a preconceived idea of the right way to behave in labor, and this has to do with, different cultures. The different cultures, women, the way they respond to pain, they can be anywhere from very stoic or just screaming their head off, depending on what they see as acceptable for the different cultures. Some cultures prohibit any kind of male caregivers being in the room. Some cultures take the placenta home. Some require certain nourishments during labor. For instance, some consider labor to be cold, so they only drink warm drinks. So it's just always important to listen carefully and explain the rationales of why you're doing things, and then get the feedback from the patient or their support person to see if it's acceptable for their culture. In a lot of cultures, fathers do not participate, and of course in American culture it's very, very common for the significant other to participate. For non-English speaking in labor, you can use an interpreter. The best thing to do is to use whatever service the hospital has, for instance, whether it's ATT, whatever language line the hospital has, It's not always best to use a family member because sometimes they tell patients what they want the care for them to have. For instance, they may tell the nurse that the patient does not want anything for pain when in reality the patient does. So the patient family member or relative or friend is not the best interpreter to use. The physical exam for the general systems assessment, you're going to assess just like every other patient from head to toe, listen to their heart, lungs, do a skin assessment. You're also assessing for edema. Vital signs, you want to know the initial blood pressure because that's used as the baseline for the rest of labor. You want to assess their blood pressure between contractions. It's also important to compare your admission blood pressure to the blood pressures on the prenatal record. You monitor the mother's temperature for infection and dehydration. So if the mom has a fever, that can be indicative of an infection or a mom who's dehydrated. So the boxes underneath that show abdominal palpation, which is the Leopold's maneuver. That is 4 specific palpating movements. I will also post a video for you to watch that. So with Leopold's maneuvers, you're identifying what fetal part is in the uterine fundus, where's the fetal back located, and what's the presenting part felt. We know that we hear the fetal heart rate the best over the fetus's back, so that's why it's important to palpate. Assessment of fetal heart rate and the patterns, the point of maximum endpoint, where you can hear the fetal heart rate the best, like I said, is over the baby's back. If the baby is vertex, the fetal heart rate is usually heard below the umbilicus, below the mother's umbilicus. And if the baby's breech, the fetal heart rate is usually heard above the mother's umbilicus. It's also important after the mother's membranes rupture to do a vaginal exam and to listen to the fetal heart rate to rule out a prolapse cord in case the cord came out when the water broke. And that would happen if the presenting part, which is usually the head, is not well applied to the cervix, and that leaves extra room for the cervix, for the cord to slip under the presenting part and out into the vagina. For the next slide, assessment of uterine contractions. We have covered this, so you want to assess the frequency, the intensity, whether they're mild, moderate, or strong upon palpation. We discussed in class on Thursday that if it's mild, it feels like the tip of your nose, moderate, your chin, and strong contractions feel like your forehead. And what that means is when you palpate and push on the fundus, can you indent the fundus during a contraction? Vaginal exam, you want to evaluate the cervical effacement, the dilation, and the descent, and that's the vag exam that we've discussed where the patient might be 3 centimeters, 50% effaced, and like a -1 station. Perform vaginal exams only when necessary to avoid infection after the membranes rupture. So usually it's no more often than approximately 2 hours as long as the labor is progressing normally. But once the bag of water ruptures, it's easier to get an infection if you do too many vaginal examinations because you're introducing the bacteria in the vagina up into the uterus, called an ascending infection. There are graphs that you document the vaginal exams on, and there were some examples in your book, and what's good about those is you can compare if your patient is progressing normally. On page 443 it shows a couple of diagrams, and that, like I said, it shows whether your patient's progressing normally.